Hello, everyone. Okay, we've got the microphone that works. Yes, so I'll pass this one around. All right, we just heard very different ideas about how to make healthcare affordable. And as a physician, I want to begin by grounding us in the patient experience. I'm an internal medicine hospitalist, and during the COVID-19 pandemic, I provided care at Denver Health, the safety net hospital. During that time, the hospital was full. We couldn't keep up. And oftentimes, during that first month, even patients that were medically ready to be discharged could not be discharged because they had no outpatient health insurance. They were completely uninsured. And so discharging them with oxygen was not possible. We had a collaborative relationship with our state Medicaid agency and relayed this information. And our state Medicaid agency expanded the emergency Medicaid program to include outpatient benefits so that we could discharge our patients with oxygen. It was a fast change, almost overnight. And as Adam mentioned, it was a moment of collaboration, of course, because we were in a public health emergency. But what this did is it had a domino effect across the country such that other states also expanded emergency Medicaid to help this patient population. And so I think, as we consider these different healthcare policy ideas, it's important to think about how much of this is not abstract. And it directly determines who gets care, who gets stuck, and who is harmed. And so I want to begin with Noam, a question for you. You are reporting, and I'm curious to hear from you what the public opinion is on some of these ideas that have been shared today.
Thank you. Still working. Well, thanks for the question. Thanks for having me. Thanks for putting this conference together, guys. It's a really great opportunity, I think, to talk about these issues. And I also want to actually start by maybe grounding this a little bit in the patient experience. I am a healthcare journalist. I've been covering healthcare for the last almost 20 years now, which I realize makes me kind of like a babe in the woods compared to some of you. But nonetheless, I spent a lot of time traveling around the country and talking to patients. And I'm going to share with you a patient story maybe to get started. We've recently been doing some reporting in Minnesota, looking at charity care spending by hospitals in that state. And one of the patients we met was named Corey Roberts, who lives in a town of St. Cloud, Minnesota, about an hour and a half from the Twin Cities. She, a few years ago, got divorced. She was a former stay-at-home mom, and she re-entered the workforce. She got a job for about $41,000 a year in HR at a nursing home. And then she was diagnosed with early-stage cervical cancer. And medically, it wasn't particularly complicated. They treated her successfully. But she was left with $8,000 in medical bills. And she did not qualify for financial assistance because the health system that was taking care of her, called Centricare, had a very low standard for providing aid to patients, and she made too much to qualify. She had health insurance, but the health insurance did not protect her adequately. She scrimped, she saved, she did not buy Christmas gifts for her children. She paid off about $6,000 of that, but because she had an outstanding balance, the hospital sued her. And then they finally dropped the case when she took a loan out against her retirement account. And when I hear these kinds of discussions like we had at the beginning of the last panel, I am always thinking about people like Corey Roberts. And I'm thinking, what did we just hear would meaningfully change her experience? Not just medically, but particularly financially. And when you ask sort of what public opinion suggests, I can tell you from personal experience, we have a pretty robust polling shop at KFF, as many of you know. It is costs, costs, costs. And costs meaning costs to the patient. The out-of-pocket cost, what it costs to go to the doctor, to go to the hospital, to go to the pharmacy counter. And we just did a new poll, actually, that specifically asked people if they could make one change to their health insurance, what would it be? 45% said lower my out-of-pocket costs. That was more than twice the next option, which I think had to do with prior auth, and like 4 times as high as like ensuring choice, and interestingly, ensuring value. And so there's a lot of talk, I think, in our discussions about health reform, about cost and restraining costs and creating market incentives for reducing costs that government pays that employers pay. And not to blame the architects of the Affordable Care Act bending the cost curve. That was meaningless for people if they get stuck with $8,000 bills when they go to the doctor. And so I would suggest that more than anything else drives the way people think about health care and health reform now, and ought to be sort of the North Star for kind of how we think about what the next step is. And maybe I should stop there and hand it over, but that's kind of my first reaction.
Thank you so much for that very grounding and powerful story. Fred, I'm going to turn it over to you. You're CEO of one of the largest safety net hospitals in the U.S., and I'm curious your opinion on some of these health policy ideas, especially considering the patients you provide care for, many of whom are uninsured, underinsured, or structurally excluded.
Yeah, thanks, Lily. So as I was sitting there listening, I was thinking, okay, I'm going to put my dots firmly on the flip charts for Adam and Hayden, because when we see what's happening at the hospital level, this idea that somehow if we give patients more information, if we give them more ability to choose, they're going to be able to sort of make the right choices and drive costs down. It necessarily involves, if that's going to drive costs down, it necessarily involves making them price sensitive. And as Adam talked about, you just see too many examples of where that has a negative impact on the patients themselves. You see it in studies and surveys of how that happens, but you see it firsthand as well. Adam talked about people in the ICU. We see people all the time that come in with late-stage cancer who avoided care because they were worried about costs, or the first time you see them in the hospital, I mean, I can walk through the hospital and see the person whose foot is elevated into this bandage, and you know that that's a person with diabetes who's had an amputation, who has not had care for the past 10 years, and this is how they show up and present to the hospital. And oftentimes that is because they can't afford, or they're afraid of the cost. We had somebody tell me about a year ago of an experience they had in the emergency department at a safety net hospital where we have very generous financial assistance policies. And when they were explaining the financial assistance policy, someone was so concerned about that they left someone who was suspected of having sepsis. And so the idea that we can put that burden on the patients to make those decisions as a way to drive down costs, it hasn't worked. And I don't think it's going to work. It does, hospitals are open 24/7. Those are real costs. You've got specialists that need to be available 24/7. Those are real costs. Adam's points about driving administrative waste, excessive profits, those have to be addressed. And I see 2 things to address here. One is patient access, and how do you make some system that patients can tap into? And this is, what I did here that was encouraging was pretty general agreement for some universal coverage, some way that we cover everyone. The other half of that is, how do you drive down the costs too to make that affordable? And as a hospital, I don't think you can look at and say, okay, hospitals, tell me the plan to make that happen, because you're one piece of a system that has insurers and doctors and pharmaceutical companies, and everybody's going to point at everybody else, and you're in a system that's designed to driving profitability. And so until you address that piece, it's not going to, I don't think that's going to be resolved. And so, Adam's discussions and Hayden's discussions about cooperation, coordination, regulation, I think are necessarily going to have to be components of this if we're going to expect to cover everybody and address costs.
Thank you, Fred. Jeanne, now to you. You were Health Secretary of Maine during the COVID-19 pandemic, again, during a time where there was collaboration and coordination. You helped implement policies to keep people covered and able to access care during this crisis. From this experience, where are the opportunities for bipartisan change in a crisis, and what are the limitations?
Thank you so much, and thank you again for inviting me to this conference. Already I feel like I've learned things. I will go to a more positive kind of experience, and it does sound strange to say a positive experience during a very dark time when millions of people suffered and died. But from the beginning of the pandemic, people rolled up their sleeves. We immediately made healthcare free, period. Didn't matter what kind of insurance you had, no copays, no cost sharing to get anything related to COVID or that next circle around it of care. We did that through emergency rules, other policies. We just made it happen. We also then looked at modalities. Telehealth became used by 60% of people in Maine at the peak of the pandemic. And we really were able to get to people where they were, and recognizing that people like pediatricians were not seeing kids. I mean, they were almost going out of practice, couldn't pay their bills in the fall of 2020. We did emergency per member per month payments for all of our physicians, just to keep them floating, to keep them talking, to calling their patients, to doing outreach when the people weren't coming in. We really engaged our communities. We took some of the federal funding and created a Healthy Maine Communities program, which we gave to any municipality to do whatever they could themselves to make their town safe. So that summer in Maine, we had lots of moose wearing masks all around the state with logos, lots of communities putting up barriers so people could go out to parks and not be too close. We really had an all-in-all effort on the health component, to say nothing of our private sector and businesses kicking in. One more note, going back to this cooperation point, thank God we didn't need alternative care sites in Maine, because our regional hospitals, our rural hospitals, some of which were bankrupt, going into bankruptcy, said, here we are. So we got from the federal government an ambulance transport for non-emergency transportation and moved our kind of step-down patients out of our kind of level 1, level 2 hospitals to these other hospitals, and maintained a situation where we were able to care for people through just sheer cooperation. There was no formal agreements. We met often. We communicated. And I'll just pivot to the bipartisan part. My team did weekly emails to the entire legislature. We did regular briefings of what we were doing. We went to them and got approval for some of the activities we were doing just because we wanted that ratification. And at the end of the day, some of those policies became permanent. You know, Maine did get kind of a high score on the National Bureau of Economic Resources scorecard, which is a conservative grading for our performance. And I think that was in part because of the cooperation and the way people were able to meet the moment. Did it last? No. It wore off like it wore off everywhere. But I will just say, before we turn away from that moment, the two elements of it that I think we should all try to figure out how to capture is the common sense of caring and decency. People say, we care about our neighbors, we care about our friends, our families, our school kids, our elderly people, and that overrode some of the political differences. And the second was cutting through the process. We had to earn the trust, but we got the trust. And we were able to just move fast because they recognized the urgency of the situation meant action, unusual action, not going through the usual process was needed. I keep wondering if there's some way that lifting the stories of that person from St. Cloud could be a way that we begin to create both that sense of commonality and urgency to break through the differences.
Thank you. I want to build on one of the questions that was asked during the last panel, which is, what a unique opportunity to all be here today, regardless of differing opinions. And, you know, if we are all grounded in the idea that we want to reduce patient harm, where is there commonality? And where does this conference take us? We're all in this room together. And so I want to ask a question of all of our panelists. What are your thoughts on how we move forward, finding commonality, finding collaboration? Where do we go from here? And I will open it up to any of you.
Thanks, and thank you very much for that question. And thank you for raising that in your comments, Jeanne. So we're actually starting a project now called Common Ground in Healthcare at KFF and NPR, who's the publication partner. And part of it grows out of a sense that I picked up traveling around the country, that there is actually more that Americans agree on about healthcare than people realize, and I think more than our previous panel might have suggested, even though actually I think there were some interesting areas of agreement there. And some of those points of agreement are obvious in the sense that we all share similar frustrations about cost, about the administrative complexity of the system, anger at the greed, frankly, in the system. And there's polling that suggests this clearly. But there's also evidence emerging around the country, I think, of where people are doing exactly what Jeanne just described, where they're rolling up their sleeves and they're working together on issues where they actually agree on. And we're going to explore some of these as part of this project, but I'll give you a couple examples that are sort of on my story list. The one we're coming out with next, hopefully in the next few weeks, is a very small one about medical debt, which I've spent a lot of time in that world over the last few years. But I spent some time with a church in North Carolina, very purple congregation in Winston-Salem, that has been raising money to buy up, working with undue medical debt, to buy up and retire debt in the surrounding community. And the pastor there told me he wasn't sure at first whether or not the congregation would go for it, because there's Republicans, Democrats, Trump voters, Trump haters. And he said, you know, there's certain issues like immigration or even student loans that were too divisive for, you know, to take to a congregation. But when he raised medical debt, there was such a visceral sense among the congregation that this is just not something that Americans should have to endure as a result of getting medical care, that he said it's the easiest money he has ever raised. And I interviewed a woman who works for a health system down there, voted for Trump, described herself as conservative. She said, I see people going into debt every single day. I don't think it's right. So there are little things like that. The polling suggests 80+% of people believe there should be public laws that restrict aggressive collections, that force hospitals to provide more assistance. But even if you take it up a step, you look at regulation of prices. Indiana, which I know we're going to hear about later, is also on the list of states we're going to hopefully be reporting on that have gone in there and said, you know, prices are too high. We should come in there and do something about it. And interestingly, I have gotten to know one of the pollsters who works for the president, Fabrizio Ward. And Bob Ward's been doing some healthcare reporting, healthcare polling, and they polled Republicans, Trump voters on price regulation. And the interesting thing is that still Democrats are more open to regulation, as you might expect. But price regulation for hospitals also has pretty strong support among Republicans. And they wanted to understand, I think the question they put to them was, would you favor a cap of like 250% of Medicare prices for hospitals? And they wanted to understand why were some Republican respondents not supporting that. And they went and they did some focus groups afterwards. And some of the responses they got back from people were, 250% of Medicare? Why do they get paid 2.5 times as much as Medicare? That's not fair. And so I think this notion of fairness converging with ideas about kind of how the government can get involved in ways that are actually like Switzerland, like Germany, like the Netherlands, places that have private systems but have regulation. I think there's a lot of opportunity for common ground.
All right, Noam, you've made me think about a few things. I do think the issue of medical debt and cost, it's gotten beyond just an issue of concern for people without insurance now. You know, it used to be this was 15% of the population uninsured. It was much easier for the general population to ignore this, right? Because still 85% were insured and had pretty good access. And now what you're seeing is what Vikas described in his opening is this widening gap where you've got, you know, a smaller and smaller percentage of people who have good access, a much bigger growing group of people who are either uninsured or insured with insurance that's not really helpful. And so this issue of cost and affordability has caught people's attention. Medical debt is something that we discuss quite a bit in our sector. And there are things that hospitals can do, and hospitals are doing now that the light is being shined on this issue. Not having fair billing practices, not suing your patients. Being more forthcoming with your financial assistance policy so people don't have to go and search for them. I think you could do more in that space, standardize what the expectations are in that space. But still, that's one relative, that's important for those patients, but it's a small piece of the overall issue of affordability. You mentioned people being more sort of open to this regulation. It reminded me of a poll that KFF did probably now 5 years ago or so with executives from the Pacific. It was not the Pacific Business Group on Health. What is it? The big employers in the Northwest, where like 85% of these big companies said they wanted more government involvement in healthcare, in prices and healthcare regulation, which was just astounding to see that level of support among big employers, business community. But it speaks to the issue of, this issue of cost has gotten people's attention. I'm not the Washington insider person, so but I'm pessimistic that you're going to get big solutions coming from there. And so you're seeing states now step up. And Jeanne, I'm interested in your point of view on this. I know in Texas, people are talking about things like this continuum of how to address affordability, from things like all-payer claims databases, so to be able to look at that to help gauge the market, but also that leads to decisions around, okay, what do you do with that information now in terms of setting policy and putting price caps and regulations? I think some of the other things that people can probably more easily, or you get more general agreement on, or in that space, programs that are generally targeted towards safety net operators, 340B programs, Medicaid supplementals, DISH, like to really target those because in many cases those programs have gotten exploited and just been used to generate additional profits. And so sort of more focused and targeted intervention on that, you can get a little bit more general agreement on that. But ultimately it does, I think it begs for sort of larger solutions. And in the absence of federal action here, you're seeing states do more and more. And maybe I could turn it over to you, Jeanne, because
Sure. So in Maine, I think in every session, the last like 3 or 4 years, have passed some policy to address medical debt. Most recently, it was preventing garnishing of wages for medical debt, for example. But medical debt is a symptom of a problem, right? The problem is higher prices and inadequate coverage. And in the same session, there was legislation introduced by all the leaders in the legislature that would address a problem we have in Maine, which is access to primary care, access to behavioral health. So it would raise the minimum payments for those providers to it ended up being 125% of Medicare rates. So it was above Medicare rates. Those would be the minimums that private insurance would pay for behavioral health and primary care in Maine in return for, at first, caps of hospital prices. That went away. Then it was a cap in the growth of hospital prices, and that went away too. The legislation, despite support across the legislature, failed publicly because the lead hospital said we would have to close our NICU if this happened. We would have to shut down our level 1 trauma program in Portland, Maine, if that were the case. And then behind the scenes, it was even the rural hospitals that were primarily exempted said, one big beautiful bill act is on the horizon, all the cuts with provider taxes, et cetera, are coming. We can't do both. Rural hospitals will close. So I think we have work to do to connect the dots between how would that piece of legislation, for example, help the typical family. The typical family in Maine is we're like 32nd in the nation in median income, and we pay amongst the highest prices for private health insurance, we could not effectively translate that into this bill would mean this for you. And that's our fault, and we need to do better at that.
Can I, do you mind if I? So I think that's really, really interesting, and having covered the debate over the Affordable Care Act, I think one thing that sort of became clear to me as a reporter was exactly that disconnect. And I think it's something, it's a disconnect that exists on the left and the right, I think, because these policy discussions can become very abstract, and people don't see the benefit of why I'm doing something, right? And I know I'm sounding like a broken record, and I know some of you have heard me talk about this ad nauseum, but I think it's hard to overstate just how viscerally appealing the limit on out-of-pocket costs can be. So I spent a lot of time in Germany, which I would argue, I don't know what happened to OVIC, is a better comparator actually than Switzerland. My family lived in Switzerland for 25 years. And I can tell you, that's the first time I've ever heard anybody say that Switzerland should be an example of keeping costs low. But they are better than us. But Germany is a much more complicated, multicultural society, much more comparative to the United States. It has more problems with its health insurance system, but it is largely a private system. But the one thing that's really interesting about regulation, and I thought a lot about this in the context of what Hayden was talking about with the sort of progressive regulatory impulse, is that yes, there's a whole mechanism for controlling the prices, but the payoff for patients that they see is that it's 10 euros maximum if you fill a prescription at the pharmacy. And there's a whole back-end system for making sure that that works that has to do with technology assessment and so forth, that ironically now the Trump administration wants to borrow, right, with most favored nation, but that's a separate discussion. But there's a limit on 10 euros a day in a hospital. Going to the primary care is always free, no matter what health plan you have. And so that standardization, I think sometimes people don't, the standardization of costs and of structure, people don't, I think it gets lost on the policy community, that those are ultimately kind of what I think people want most, and that the language that people use to talk about what they want and what they expect hews to those very simple principles, not to sort of, is it Medicare for all or not Medicare for all? Is it a market? Is it not a market? Are the prices regulated? Are they not regulated? It's like, for them, what does it mean? And I feel like that's sort of where the discussion can go, because that's where people actually agree.
And I'll just add on the way back to you. That I think is because we're at a time when people don't trust government. But you're describing a policy that is the outcome, not a policy that says if we cap prices, then that money will go to the insurance company, the savings will go to you through an indirect way, and you will, we estimate, save this amount. And I think that's something that all of us policy people have to learn in a time when, on the previous panel, they discussed how hard it is to get things done at the federal level, even at the state level. I think we all have to think about our approach to policy, not just what we're trying to do, but what we're trying to achieve.
Thank you all. One thing we haven't talked about is physician harm. We've talked a lot about patient harm, but in this, there's also a lot of physician harm. Our team has conducted several qualitative studies, and in asking clinicians who work in safety net healthcare systems about their perspectives, many of them face moral injury, moral distress, as a result of not being able to provide patients the care they need, the care they deserve. Many of our patients don't have options. We discharge patients with metastatic cancer and no follow-up. And so even considering, sort of everyone that experiences harm, physicians are one group, and we're seeing a lot of turnover. And so, Fred, you are a physician and CEO of a healthcare system, and I'm curious about your thoughts. And as we transition over to Fred responding to this question, if anyone has questions, if you'd like to line up, we'll move over to questions soon.
Yeah, thanks for that, Lily. This is probably the biggest headache I have as CEO, and I don't mean that in a in a bad sense, but it is the one issue that just gnaws at me all the time because it's always present. And when you talk to our physicians, the biggest frustration that they consistently express is the rules on who you can see, how you can get people in the system. We're a county hospital, and so we have rules about, county residents for our financial assistance. And physicians just want to see the patient in front of them. They want to take care of the patient and in front of them. And I am sensitive to, I was secretary in Louisiana for years ago, and I am sensitive to this issue of, the providers wanting you let me just see whoever I need and do whatever I need, and you pay me for that. I realize that there's a sentiment. But in our system, it is a frustration because there is not a consistent ability to see, even in our system, everybody regardless of what their demographics are in terms of where they live, what their financial situation is. And so we're undergoing a major effort right now to just totally simplify our financial assistance process for the safety net. For instance, I can't go to a Rotary Club in Dallas and talk without somebody saying, how much care are we providing for people outside of Dallas County? Because you got Dallas County with a very robust system in Parkland, and then all the other counties that have very little, and people with serious conditions come into Parkland for that care. And it irritates people in Dallas County who are paying taxes to support Parkland, and the surrounding counties have low taxes, and people are coming to Parkland for care. So it's an ongoing frustration. But I tell you, I think it causes you to question what your policies and what drives it. And I think fear is behind a lot of that stuff. In business school, people are taught, you figure out how to get people to pay and exclude as opposed to being more open. And so we're challenging that, and it's causing, people to get anxious about it because, if we liberalize too much, for instance, can we just automate this and say, we know where you live, so it's likely you're going to be under 250% of poverty, and so therefore you're eligible. End of story, right? It gives the financial people a lot of heartburn because they're worried about people gaming the system and people coming in for care. You're always going to have that, but I think we spend more time on trying to identify that 5 or 10% than we would relieve if we just made it more liberal for others. Vikas mentioned, the admission for somebody, the workaround to get an MRI. I can tell you when I round sometimes with the teams, I don't practice, but sometimes I'll round with the teams, and the residents are great. They will tell you everything. And so, rounding with the GYN oncology team, and they explain why this lady is in the hospital waiting for an elective thing because they're concerned if they discharge her, she won't get financial clearance to get back in electively, and so they admit her from the emergency room and hold on to her till they get OR time to be able to. That's an incredibly inefficient thing to do, but it's a result of doctors trying to do the right thing, take care of the patient, and sort of work around the policies. And so the more we can simplify administratively, it's not only, it will go a long way towards this issue of moral injury and physicians being concerned about not being able to practice. I think one of the things, you're on the board of Denver Health, that we can do as physician leaders is try to make it easier for physicians to see the patient in front of them.
Thank you, Fred. We can move on to questions now. I think we've got 3 people lined up over here.
Thank you. Ian Lewis. I'm with Unite Here, the Hotel and Restaurant Workers Union, and I'm on the board of the California Office of Healthcare Affordability, which means my day job is to fight companies that own buildings like this one and extract money from them and hand it off to the healthcare industry. And then represent workers both as purchasers and as payers, as patients rather. There's vast variation within the country and by market in terms of price and provider practice patterns. And so we, as purchasers, as payers, find our attention split between focusing on policy interventions that might bring prices down and creative care management benefit design strategies to manage utilization. But we don't have 15 years to wait. Our members are, that next group of people who are going to lose affordable health coverage to the extent they have it. Where would you recommend we focus our attention over the next 5 years? How do we split that? How do we maximize that effect? Ideally in a way that is coherent across the country with such variation.
And thank you for the work you do, because it really is very important. I go back and look at positive lessons from the past. And, back in the 2000s, I was a staff person to a group called Better Care Together, Better Healthcare Together. And it was unions and large companies, including non-unionized companies. We both had AT&T and we had Walmart in this coalition. And they figured out very simple but real concrete vision, ideas for the healthcare system, and went around to say, you have to do something, members of Congress. Going back to the capture that we talked about before, yes, there's certainly health sector capture in DC, but boy, you name the senator or member of Congress who's not going to take a meeting with the CEOs of these major companies and the heads of their union. They do. And in that, listening to the frank conversations about what this means to business bottom lines, what this means to workers. I mean, Vivian Ho and a colleague keep doing a chart that shows from like 15 years ago, regular inflation, wage growth, health insurance premiums, both for out-of-pocket and employer, which doesn't even count cost sharing. We just need to make this more visible and get the urgency. The urgency then, I think, maybe create some of the solutions or space for solutions, space for the bipartisan ideas or agreements that we talked about earlier. But I don't think the business community in this country is pushing hard enough. And I think, unfortunately, people like you are just on the front lines trying to protect people. And we have to figure out how to bring that together to create some sort of pressure, state and local, to get something done. That's my 2 cents.
I guess I'll say one thing, although I'm at risk of sort of practicing beyond my license here. I mean, having watched the Affordable Care Act and the way that legislation came together, and Jeanne, correct me if I'm wrong here, but I think it was very much the product of a lot of stakeholders kind of coming together. It's part of the reason why the capture became a problem, but arguably there wouldn't have been expansion of coverage and protection. And there are a lot of problems with the ACA, but I don't think we should lose sight of the fact that millions of people gained protections that probably saved people's lives. And that's worth something, even if it's been a mess over the last 15 years. But I think one of the challenges now, I wonder, is sort of how to re-engage the stakeholders, since what we're really talking about is making everybody sacrifice now. It's not just everybody gets in on it. Like now it's sacrifice, and that's obviously super, super difficult to do in DC. I'm a former State House reporter. I think my experience working in state houses is it's easier in many respects, notwithstanding obviously it doesn't succeed all the time, but the players are closer together. But I'm thinking about a conversation I had recently in DC with a panel of the American Hospital Association. And we were talking a little bit about kind of how one addresses some of these stresses on patients. And I was doing the shtick I just gave you before. But one of the things we were talking about was, what is it worth to the hospital to not have to chase after patients? Like, that's worth something. It's worth something morally, I think, for the people who work. And most hospital people I meet, even the ones who work at these behemoths, with a few exceptions, seem to have gotten into healthcare for the right reason. And they want to take care of people. They don't like suing people. Sometimes they pretend it doesn't even happen because they feel so uncomfortable about it. But that it's worth something to give something. And like, if that's the frame that the conversations start with, like, I have something to gain out of this conversation. Like, it's not going to work for United, okay? It's just not, right? It's probably not going to work. It may not work for Partners. But there's a lot of people who are really, really suffering in this current system, like physicians maybe more than anybody. And it feels like there's an opening there, just the shared misery, if nothing else. Anyway, that's a thought.
Thank you.
Hi, my name is Chi-Chi Wu. I'm with the National Consumer Law Center, which is a consumer advocacy group. And my question sort of plays maybe along Noam's last comment, and is for Noam. So we know in this country there's a lot of conversation and probably a lot of anger around affordability generally. Affordability of rent or housing prices, gas, childcare, groceries. And you know, medical bills are probably part of that conversation, but we see the statistics, 80% of folks are concerned about the cost of medical care. Is that yeah, that kind of sucks, we're concerned about it, or is that, you know, let's get out the pitchforks? For me, it was kind of striking the last panel how folks could talk about United Healthcare and not talk about Luigi Mangione. Sorry to bring that up. Not sorry. You know, in your conversations with folks across the country, are you getting the sense that this is an annoyance or a pitchfork level event?
I mean, having never actually experienced a pitchfork level event, I don't know, but it feels like there's something very visceral there. And the thing that really strikes me more than anything else about it is how widely shared it is. That it's not just like a bunch of liberals who want Medicare for all who are ready to go into the street. I mean, I've been on focus groups with Trump voters who are absolutely irate at their local hospital. And I think it's interesting that some of the strongest efforts to hold hospital systems accountable are now in like really red states like Texas. I mean, there's a very robust, Fred can probably talk about this more than I can, very robust effort in Texas to go after the tax-exempt status of hospitals for not doing enough to help their patients. And so it feels like there's something more visceral going on, but I don't know.
Yeah, I mean, just to follow up there, that's a real thing. I mean, I think the states are taking this on because, you know, they're closer to the action. You're hearing from employers in the states. You know, it's gotten to a point where employers are paying much more attention now. It used to be that's not part of your business. It's an expense, but you can no longer treat it like a sort of a side expense. It's become a very significant expense. And so when more and more employers, big employers, are paying attention to this, I mean, we've got the person who's leading the affordability committee that the legislature has commissioned in Texas, who his home company is suing the PBM that's providing the pharmacy benefits for their company. And so, yes, I think it's reached a point where you're seeing people act in ways you wouldn't have seen just a few years ago.
I think what's important is that regardless of our political ideology, we're all at risk of being diagnosed with cancer. We're all at risk of having huge medical bills. And this moment in time with all the healthcare policy changes, this day that brings together people with differing opinions, feels like a momentous occasion for people to come together. And it really is, you know, interesting. We're talking a lot about patient harm, but who else is harmed? The healthcare systems are harmed. Physicians are harmed. All clinicians are harmed. And so how do we come together and leverage our professional societies, leverage each other's knowledge to come to some sort of solution? So, Katie.
Hi, my name is Katie Rizzolo. I am a clinical nephrologist and clinician scientist at Boston Medical Center, Safety Net Hospital in Boston. And when I look at the name of this session, to me it seems I'm an implementation scientist, and it looks like implementation science. How do we put policy into context? Dr. Lambrew, I was the chief resident at Maine Med the year of COVID. Some of those policies, I had like a physical reaction to remembering them because we were implementing them. And I noticed that, you know, implementation plays such an important part in policy down to the individual departments. The Department of Medicine did this different than the ICU, and we were in the middle. I see this at the institution level, that when Mass Health changes the rules on what they're going to cover, BMC does this different than the community health centers. What role do you all think that policymakers play in the actual implementation of these policies, not just what they are?
Thank you, and that's a great question, and thank you for your work during that very difficult time. So having worked in the 2000s in advance of the Affordable Care Act and working on the Affordable Care Act at the Office of Health Reform and HHS, policymakers were very intense on looking at the policy, the politics, how it's paid for, what do we need to have happen when. That implementation was not high on their radar screen, and in fact, I remember losing the fight for trying to make sure we had sufficient funding for implementation. Lost it at the last minute, and I lost it because the leaders in Congress said, we don't have enough for cost-sharing subsidies. So I'd rather you go find the money to implement it, but we're gonna spend another $9 billion to help low-income people afford coverage. And that's a trade-off, that's a hard one to argue against, but that's what happened. And we worked very hard. There were many things that got delivered and organized on time and in advance, but I have the dubious honor of being one of the 10 people who should be fired over healthcare.gov failing, according to Politico. Having been involved in that, exactly, barely. The lesson here, a very short story, is it recovered. We actually got the number of people we hoped to enroll in that first year. And President Obama created a role, Deputy Chief of Staff for Implementation. And we inculcated throughout everything that followed having a policy person, a legal person, a communications person, a provider liaison, a tech person, an operations person in every policy development, so we would actually be able to do it. And I will just fast forward and say, not only is that lesson not lost on almost everybody I know who does public policy these days, people don't ever want to be in that position. And trust me, going back to the moral part of it, we were having people have their neighbors put hand-filled in applications under their doors because the website wasn't working, because they were so desperate for healthcare. So it was not lost on any of us. And I think many generations follow that, have been learning that, is now taught in public policy, is now taught in cases. And my last positive story in that is learning that lesson. Our health reform bill developed in 2019 and passed just before the pandemic shut down would create some early deliverables that were easily done. We had to prove that this could work immediately. No copays, no deductibles for a couple primary care and behavioral health visits in all state-regulated insurance. We got kind of a plan to do a state-based marketplace with public checkpoints to make sure it was working. I hired somebody who, again, was deputy for implementation who did it, and we actually pulled it off on time during the pandemic to launch a state-based marketplace in Maine. So it can work. There's lessons out there, and I think it is something that policymakers are so much more attuned to, and I'll just go back to the word trust, especially now. Trust in government, trust in all of us is much lower than it was. The whiplash of the last few years has really created anxiety about government. So I do think implementations can have an even bigger seat at the table and role in planning as people are considering the next round of health reform.
Thank you. Next question.
Hello, Adam Fox again from Colorado. There was a fair amount of conversation on this panel about sort of moral injury, and I think one of the issues that I've been thinking about a lot lately, while we are very much a patient consumer-focused organization, we try to work a lot with providers and gather their input and perspectives. I think we see an increasing challenge for providers who feel like they cannot speak up without putting their careers, their livelihoods, and their ability to sort of support their families at risk. We see examples when providers go to speak up on health policy issues of health systems going after them and making their lives either living hell or essentially firing them. And so I'm curious if you all have thoughts, because I think providers and consumer and patient interests often align a lot in these conversations, but it feels increasingly like providers' hands are tied in their ability to advocate. And I think that's contributing to the moral injury question.
Thank you so much for that question. It's interesting because what I'm seeing and Fred, I'd love your thoughts, and everyone else too, is what I've seen is a lot of motivation, I think, from the clinician perspective to lean in and engage in advocacy as a way to reduce that sense of powerlessness and hopelessness that I think feels very compelling during this moment in time. And as a way to build public trust, it compels all of us as physicians to be more involved and engaged. And I think many professional societies are making it more possible. So they're offering advocacy training. Many professional societies now have advocacy committees as well. And then there are many foundations that are also really considering the role of physicians in advocating at every level, at the patient level, at the city and state level. I think it is within, our profession to be engaged. It is the right ethical thing to do, to be engaged, to build public trust in this way. And so many of us do engage on our own, not representing our healthcare system, of course. But I'd love to hear from Fred. I keep turning it over to you, Fred. Sorry to put you on the spot. But I think many of us do connect with our healthcare systems to say, hey, I'm going to advocate on this. And for the most part, as long as we're representing ourselves or working within our professional society, that's possible. And again, I'm seeing more motivation, more desire in this space. And so, again, I think this moment in time, this opportunity today, is a time to really sort of leverage our professional societies, our foundations, each other, to really find common ground in this space.
Yeah, I appreciate that question as well. It's a conversation we're having a lot of right now. The ABIM Foundation is talking about this, and the times of people having their own practice or small practices where they control the decisions is gone. Such a high percentage of physicians now work for either a health system or a big group practice, that the situation you're describing is become much more front and center. We had a big meeting last summer where this was a topic of discussion, and one of the things that struck me that came out of that was this comment by one of the speakers of, listen, you guys, physicians now, you still have a lot of agency. People listen to you. And Lily talked at that about how she changed Medicaid rules in Colorado to cover people through Medicaid for dialysis who before that time were going through the emergency room sporadically and dying because they didn't have access to care. And it was a great example of how physicians can take leadership to change their systems. I know at our place, the physicians have a loud voice in terms of being able to identify issues. And I would have to believe, I'm an optimist, but like most systems still want to be responsive to that and understand the issues and be responsive. So on top of that, for those that don't want to be, there are things like corporate practice of medicine laws that need to be, enforced more. Anti-competitive things, the non-competes that, you've got to be able to deal with so that physicians can feel free to express their opinions and not be worried about can they work in that city anymore. But beyond those regulatory issues, I do think physicians recognizing that they still are in a position of great influence with their institutions, and they should use that agency to affect change.
Thank you. And last question.
Thanks. So I'm Matt Fishman and have spent a career here in Massachusetts trying to make sure that low-income people get the care they need, doing that with lots of other people who know more than I do. And I was part of the Massachusetts team that helped develop the near universal coverage here that was one of the antecedents of the Affordable Care Act. Lots of problems in what we did here in Massachusetts, so I would not say that we got it completely right, long way to go. And I should also mention that I spent a lot of my career in state government and then also working for Partners Healthcare, now Mass General Brigham. I'm not here to defend the organization, and I don't work there anymore. Do now a lot of work with community health centers. Here's my question, and I say this as someone who was an emergency department administrator many years ago. To what extent would utilization actions make a difference? I know we had some discussion earlier suggesting that they might not. But when I see people, now spend more time in emergency departments as a patient than I do any other way, but in any case, when I see people there who do not need to be there, when every year the state data agency here issues the same report on the percentage of people, most of them low income, many of them people of color, who get care in emergency departments that they could have gotten someplace else. If we invested more in community health centers and other sites of primary care and reduced that unnecessary utilization, let's go a step further, avoidable inpatient admissions, and I believe Massachusetts has the dubious distinction of being #1 in the country for readmissions. So if we did something about some or all of those, it would probably help on medical debt, but does it do anything to take costs out of the system? Because if it does, let's work on it, and if it doesn't, we got to focus elsewhere. Thank you.
I mean, I'll just be real quick. When we do our community health needs assessment, we talk to patients, you know, what comes out is they go to the emergency room because they may wait a long time, but they're going to get seen. They're going to get all the stuff they need. If they need scans, they're going to get their scans. If they need specialists, they're going to get the specialists to see them. And we've just made it so complicated for them to get all of those things outside of that, to coordinate all of that, they'd rather go spend a lot of time in the ED and get it done at that visit. A lot of times it's the entree into the system. So I do agree with you. If we had those other pieces built out really well, we might make an impact there, but I think we're far away from that, unfortunately.
I would just add that I think that, so many of you are familiar with the IHI, and whenever there's a healthcare system innovation, it is shared and there's a domino effect across the country. And I think that this is another opportunity where we can sort of begin to think about how do we reduce you know, the number of patients that are stuck in the revolving door of the emergency department as a way to build public trust. And how do we share that information with other healthcare systems so that others don't struggle as well? And so I think a lot of this is how do we work together? How do we come back to that moment in time during the COVID-19 pandemic where there was collaboration and coordination, and both healthcare systems, physicians, and people, regardless of political ideology, were working together to reduce patient harm. And so, you know, again, thinking about how do we leverage our professional societies and this moment in time to move forward in a way that makes sense and reduces patient harm. And I think that we are out of time, but did you have a follow-up question?
I just wanted to say thank you. I appreciate all that you guys have said and also these responses to the question. Thank you.